Delighted to introduce you to Henry Ford plastic surgeon, Dr. Dunya Atisha, and her colleague, Dr. Mirastella Evangelista, and Dr. Atisha's patient, Rebecca Sorensen. Tonight, we're going to be chatting about lymphedema, a very challenging side effect that many women who've had breast surgery face. Not only is lymphedema challenging in terms of your mobility, there is pain affected with it, and of course it can be disfiguring. Dr. Atisha is a breast reconstructive surgeon, but is also a specialist in surgical repair for lymphedema. And Dr. Atisha, we're going to begin with you, and then you can throw any questions that I ask over to Dr. Evangelista. So,
Thank you.
You've been a breast reconstruction surgeon. What led you to be interested in surgical repair for lymphedema?
Actually, that's an excellent question. When I got hired on by Dr. Lisa Newman at Henry Ford, at the time when she was here, one of the things that she had mentioned was that she was very interested in starting a comprehensive lymphedema program. And at that time, it was at the time when actually lymphedema was just starting to become something that some microsurgeons were learning more about, and we're starting to perform in the United States. It had definitely been happening around the world at a much higher rate, and was gaining popularity in specifically in Asian countries, but as well as European countries, but we here in the United States were not doing very much of it, and there was probably only a handful of surgeons that were actually doing lymphedema surgery. However, when I got to Henry Ford, there was clearly a need for it as we identified high-risk populations. And then we had a wonderful patient who is a patient that gives grants every year from a big fund that they have. And she was a lymphedema patient, had lower extremity lymphedema secondary to a pelvic lymphadenectomy associated with a gynecologic cancer. She donated a very large sum of money for a grant to start a lymphedema program at Henry Ford. And Dr. Nathanson and I are actually essentially the principal investigators of that grant. And so one of the sort of things that we decided to do was to build a comprehensive lymphedema program that would intimately involve a lymphedema therapist, a medical lymphedema specialist, and a surgical lymphedema specialist. Well, since I was the microsurgeon, it was deemed that I would need to be specifically trained in this. So I actually went all over the world, since it was not a part of my actual plastic surgery training when I was at Duke, because at the time it was just starting to become a thing in the United States. So I actually traveled around the world and went to sort of the big names who did lymphatic to venous bypass. I traveled to Italy and learned how to perform lympha, which we are going to talk mostly about today. And I traveled to Taiwan and I learned how to perform the vascularized lymph node transfer, and also got some experience with that in Japan. And then, I also went to New York and spent time with Dr. Joe Diane and another surgeon in Florida. So this grant really helped me take a sabbatical and get a huge exposure to all the sort of full breadth of surgical lymphedema repair from prevention to treatment. So it was really quite phenomenal. And so since then, in working with all the other specialists that I mentioned to you, including our own division's microsurgeons, we are now able to offer lymphedema surgery for prevention as well as treatment. And there are now mostly 3 microsurgeons who are doing it very consistently, and another surgeon who is offering lympha. And we are also now offering it at Wyandotte, at West Bloomfield, at Macomb, and at the Maine.
Okay, I have a quick question. You mentioned that there's a high-risk population that is at risk for lymphedema. What is that population?
Sure, thank you. That's a great question. So a lot of the studies have shown that increasing age, obesity, and patients with a history of radiation to their axilla, and of course those who undergo a complete lymph node dissection are a high risk. So patients who have sentinel lymph node biopsy, there's about up to 10% risk, 10 to 15%, that 15% is a bit on the high side, but 10 to 15% risk of getting lymphedema. But for those who have an axillary lymph node dissection Without radiation, the risk is up to 40%. And when you throw radiation into the mix, which is what we're doing these days, mostly for patients who have X-ray lymph node dissections, their risk for lymphedema is approximately 60%. So,
okay, so that leads me to a question that I didn't think of. What is it that radiation causes that increases the risk for lymphedema versus just surgery?
so one of the things that radiation is doing is that it's the way it kills cancer cells is that it's delivering a constant energy to the field in hopes of killing rapidly producing cells. So that constant energy that is being delivered to the field it sort of incites an inflammatory response.
Okay.
So the cyclic nature of inflammation and healing, and inflammation and healing, and inflammation and healing eventually lays down a lot of scar tissue. Okay. So
Okay.
lymphatics, scarring of veins, soft tissue scarring, all that contributes to the increased risk of lymphedema.
Wow. So I can see how that really impedes the flow of our systems.
Right. And now, mind you, just to be clear, I just want to be clear, I'm talking about direct radiation to the axilla.
Mm-hmm.
Okay, so a lot of women who say just had a sentinel lymph node biopsy and breast lumpectomy or even a mastectomy, if their lymph nodes did not have to be dissected and they did not have any disease in their lymph nodes, then they are not going to have axillary radiation. Okay, so if you have disease in your lymph nodes, that's likely when you're going to get axillary radiation.
Okay. So can you describe what this surgery kind of looks like? If you're telling a patient, I want to prepare you like you did Becky, how did you share with Becky how this surgery was going to be performed, how long it was going to take, and what her expectations could be afterwards?
Well, when I was with Becky, I don't know if I had this really great picture. I put together this really great picture of what it looks like. But essentially the way I describe it as a visual for patients, and I think Dr. Evangelista can tell her way as well, is I tell patients it's kind of like having a chunk of 696 taken out. Okay. And instead of cars backing up on 696, what we do is create a detour to get back on so as to help improve the flow of the cars. So what the lymphatic system does is that it drains the extracellular fluid that your cells don't want, okay? And a lot of times in that fluid, there's also proteins, and there might be some bacteria and some viruses, and your lymph nodes are responsible for acting like the garbage disposal system. So your lymph nodes are trying to process that fluid and then send the junk the extra fluid back into the vein so that you can eventually process it out throughout other areas of your body, and then you pee it out. But if you've taken out a huge chunk of lymph nodes from an area and now the fluid is backing up into your arm. So the goal of this operation is to identify the lymphatic channels coming from your arm and to reroute them to the veins that are located in the area. Okay, so we're creating that detour. We're bypassing the chunk of 696 that has been removed.
Okay, so for those people who don't know what 696 is, it's a freeway system. So I'm going to give you my brief description of how this works. I consider it like the subway system in New York. And you're trying to get from Manhattan to the east side or the west side, and all of a sudden you get to a stopping point. You can't go anywhere.
Right.
The subway stops. You can't get on the next train. So things start backing up and swelling up, and you're stuck. That was kind of how I thought of it. So how long does the surgery take? How long can a patient expect to be on a table?
So typically speaking, the lymph node dissection part for the breast surgeons has to be a little bit more technically, it becomes a little bit more technically challenging because now they're trying to save length on the veins for us, and they are trying to save the length on the lymphatic channels that are identified from the arm. The number one question is, how do we identify those lymphatic channels? Well, we eject a dye into your arm. And so the breast surgeon injects that dye before he or she does the lymph node dissection. That dye will allow them to identify the channels that are coming from the arm, and they will try to then preserve the length of those channels as well as preserve length of any veins that are nearby. So they actually do part one of the operation for us because they're giving us what we need to make the connection, okay? And then when we go in, we explore and make the connections that we can. So typically speaking, The operation takes them about 45 minutes to do the lymph node dissection, and it takes us about 45 minutes to do the lymphatic to venous bypass. Now, the more lymphatic to venous bypasses we have and we're able to make, the better off the patient is, and of course, the longer the operation takes. Typically speaking, I try to do at least 2. Some people, a lot of people only have 1 available that I can do, and usually the veins are the limiting factor. But I think in Rebecca, we did 3. Is that correct?
It is. You said you had done more on me than I think you had done at that point in time on anybody else.
Yes. Well, I beat that. I have done 7 on somebody.
Wow.
So it was explained to me that you actually harvest lymph nodes from another part of the body. Is that correct?
That is not for the prevention of lymphedema. We do that for the treatment of lymphedema.
Okay, so this surgery that you perform can prevent lymphedema, but you can also treat it post lymphedema.
That's correct.
And is that successful? How successful is that?
So I also want Dr. Evangelista to comment on this.
Okay.
Because she's here and we should also utilize her expertise as well. But the study these days show that it has about a 90% success rate in improving the softness and the feel and the heaviness of the upper extremity. However, it only improves the rate of eliminating compression stockings by about 50%. So 50% of people will be able to go on and completely eliminate compression stockings, and 50% of people will still have to wear it to control fluid, but there is a dramatic improvement in the way the arm feels. Patients will report that they no longer have that heavy feeling, that their soft tissue is soft, that they don't have the pain that they used to have. So it's effective, but not everyone is a candidate. There has to be a lot of factors that are evaluated to determine whether or not somebody is a candidate, namely compliance, BMI, other health-related issues. Are they doing everything they can and they still have a bad lymphedema, or it's still progressing? I think it's the reason why it's not performed very frequently. It's also a big operation. Dr. Evangelista, do you have anything you'd like to say about the vascularized lymph node transfer?
No, I think you summed it up. Thank you. Dr. Atisha trained me, so I can't really add to the expert here.
So Rebecca, I want to bounce over to you for a minute.
Sure.
I know that you mentioned earlier that you had some concerns about lymphedema because of your mom. Can you share that? And
Sure. Yes. So my mother had breast cancer in her late 40s. And this was in the 1970s, and she too had a couple positive lymph nodes. They took all of her lymph nodes out, and obviously there was no surgery to redirect the lymph system. At that point in time, there was also no surgery for reconstruction, and certainly that was regularly done, and certainly insurance wasn't covering that. So my mother lived another 30 plus years, but throughout that time, she had swelling in her left arm. She often sat with a pillow. She was somebody who, she loved to cook, she loved to bake, so it really did impede her life. And certainly I was aware of that. And also because of my mother's breast cancer, I was the queen of doing daily breast exams and never missing a mammogram. I had my mammogram scheduled within a 2-week period every year. And I still ended up with a breast cancer that was undetectable by most mammograms. So by the time I went through 3 various surgeries, I went from what was thought early stage 1 to stage 3. So if nothing else comes out of this, it's my soapbox. I just want every woman out there to make sure that she checks her breast every single day, because one day I didn't have a lump and the next day I felt something. And it was, when the final analysis was done, it's estimated that I probably carried that for about 2 years before I discovered it.
wow. So one of your first thoughts then was really avoiding this terrible side effect that your mom lived with for 30 years.
You know what, it was, and I am incredibly grateful to Dr. Atisha and all the other wonderful healthcare professionals I was with at Henry Ford. I've had fabulous care. I am grateful for the use of my arm. I have full use of it. I did use a sleeve early on. I certainly still use it for flying, but I have no pain. I have no swelling. But mostly, I'm really grateful for being here tonight. There was a time when I was diagnosed, I went from 1 to 2 to 3, that I didn't think I would be here 3 years later. And I am. I just had a scan. I'm cancer-free still. So I'm incredibly fortunate and very grateful.
So Dr. Atisha, I know you mentioned that you had a lot of your training overseas, and now you've trained Dr. Evangelista. How many surgeons perform this type of surgery that you are aware of in the United States?
So the lymphatic to venous bypass for prevention that we're doing, the LYMPHA procedure, which actually stands for lymphatic microsurgical preventive healing approach, is really only performed at probably a handful of centers in the United States. There's a lot of people who are still quite skeptical and don't necessarily believe that it is effective in reducing lymphedema. I can tell you that based on the data that the Italians were doing, and they were the very first people that did it, they were able to reduce their lymphedema rates from 40 to 50% down to 5%.
Wow.
We are, with, just sort of me doing it in the beginning and now all of us, and we've combined our data, and we're still at about down to 15% rate of lymphedema. So we haven't perfected the technique to the degree that they have, but we're certainly getting there, and our data and our I think our outcomes continue to get better and better. We also follow patients prospectively. So, sort of in a longitudinal fashion, they're being followed at 3 months, 6 months, 9 months, and then it goes to yearly up to 5 years. And so I think that'll give us really strong data when we finally get to that point. But the also really, sort of good thing is that the Italian data was 10 years long, and they did not show any increase in local recurrence rates or metastatic disease because we're doing this. I think that's really important, so obviously, we don't want to connect the lymph nodes if it's going to be a problem for cancer in the future, but it has not at all been shown to increase the risk of cancer recurrence. But I think, I'm sorry, you were asking me, what was your point? What was your question?
My question was, and I was going to throw this over to Becky, let's say I live in, I don't know, New Mexico.
Sure.
Can I travel to Henry Ford to get this surgery? If there's no surgeon in New Mexico or the Four Corners around there.
It's not done at very many institutions, a handful only. And people have to do some digging and ask, do your microsurgeons do lympha? Do your breast surgeons do lympha? Because sometimes breast surgeons will, but that's very rare. Just to say, I think you're going to have better results with microsurgeons. So the answer is yes, they might have to travel. Like she said, Carrie traveled from North Carolina. It was really ironic that we went to the same high school.
Yes. I know. I wanted Becky to tell that story. So she doesn't, nobody listening knows who Carrie is. So Becky, will you share that story, please?
Sure. So as I said before, it's kind of my soapbox to talk about my experience. And I've shared it with many, many people, including the people that I work with. So I can't remember the timing, if it was 6 months after my lymphedema surgery or a year after. But anyway, one of my coworkers came to me and shared with me that her younger sister, who was in her late 30s, I believe at the time, recently divorced, a toddler and an infant had breast cancer, and the breast cancer was in her lymph nodes. And she was incredibly concerned about not being able to care for her children, lift her children up. So she had made the comment many times that she was not going to have her lymph nodes removed. Her family was terrified for her. So her sister came to me and said, could you reach out and talk to Carrie? And I said, I'd be happy to talk to Carrie, but let me try and do one better. Let me reach out to Dr. Atisha's office and see if she might be willing and able to take Carrie from, I think it's North Carolina. I think you said Dr. Atisha. I couldn't remember which Carolina it was. They didn't do that surgery in her state. So within, I believe, a day or two, Dr. Atisha's office had talked to Carrie. Within a couple weeks, Carrie came up, had her surgery. And as it turns out, Carrie and Dr. Atisha went to the same high school together. I believe Dr. Atisha may have been a senior when Carrie was a freshman. And Carrie really told me later that she had always looked up to Dr. Atisha. I saw Carrie last year at Thanksgiving, at the Detroit Thanksgiving Parade, and she was doing well and no lymphedema, and just she had one child in her arms and another one in the stroller. And I'm just incredibly grateful that that connection was made, that her sister talked to me, but really that Dr. Atisha's office was so open to picking up the phone, moving whatever schedules needed to be moved to have Carrie come up and quickly have that surgery. So
let's talk about that. I think that kind of goes to some concerns around insurance. Is this surgery covered by insurance, or is it considered elective?
So we so far have not had a problem with insurance coverage. You know, we have a certain code for it. I discussed this when I was at the meetings, the microsurgical meetings that they have on international level, specifically the national ones, because obviously this is an American issue. And there were certain codes that were recommended to me. We've been using those codes, and they have been paying, and patients haven't had an issue as far as I've heard. Because typically speaking, if something doesn't get paid, patients will let me know. So I haven't had an issue with coverage. We call it a repair of a vessel, because essentially we're repairing the lymphatic channel. Excuse me, there's something in my eye. So that has been, you know, because they are cutting the lymphatic channels, and so we are repairing them to their nearby vessels, and so it has not been an issue.
So in the case of somebody like Carrie, what if their insurance won't, and I don't know if this happens, won't transfer to another state or another healthcare provider?
One of the interesting things is that there is, most insurances will have an out-of-network, you know, sort of out of network arm to it, right? That if and no one in your area provides that service, that, you know, you could potentially seek elsewhere. And, you know, with Carrie's insurance, it was fine. We did not have an issue.
That is fantastic. So I want to review a couple of things to make sure for everybody listening. So some of the high-risk patients are those who might be in the obesity area of obesity, overweight, have had numerous lymph nodes removed. And you said
Radiated and elderly.
Radiated in the axillary area.
And the elderly.
I fall into that category. What do you mean? You know what, when people say the elderly, tell me what that means to you, because every time I want to get my senior discount, they move the age up. Now it's 70 or 65.
Yeah, I think people who are 80 plus certainly have a higher risk.
80 plus, okay.
Yeah.
All right.
So we're good, Mom.
Yeah, we're good. We're good for what? So Becky, you're talking to a patient, you talk to your friend Carrie, well, now your friend Carrie. What would you share with a patient about what she, or even he, do you perform these surgeries on men if they have, well, like a male breast cancer patient?
Yes, I have. Excuse me, there's something in my eye. I think it's my mascara. Yes, I have performed these operations on men for melanoma. However, yeah, so it has to be that the melanoma is not coming from the arm. So we have to be, or if they had breast cancer and needed to have their lymph nodes removed, certainly we would perform it for them. But the melanoma cannot be coming from the arm, because then that means the melanoma will drain into the arm's lymphatic systems. So the person I had a melanoma of his back, okay? And in fact, when they mapped him, when they did the sentinel lymph nodes, it mapped in both arms. So he required a bilateral axillary lymph node dissection. And Dr. Nathanson asked me to perform the lymph on each side, and we did.
So Becky, you're talking to a patient who's concerned about lymphedema. What would you tell them they might expect in terms of what the surgery is going to be like? And I think I said this earlier, pain management following the surgery, mobility, any physical therapy required?
Yeah, you know, I can honestly say, so I've had lumpectomy, double mastectomy, the lymph node surgery, and then reconstruction. So I've had 4 surgeries. I honestly had very little pain with any of it. And I don't know if it's just the tissue involved, but I think I might have had maybe 1 or 2 pain pills each surgery. I healed pretty quickly. The biggest problem with all of them, and Dr. Atisha could probably talk about this, is the drains that you end up attaching to your body that I had for a couple of weeks. I mean, that was terrible. You have fluid that's draining and you've got these drains attached to yourself. And I needed my husband, and thank goodness he was there to help me clean those or drain those every day. And I did see Dr. Atisha often in the early stages. Henry Ford had physical therapy for me to do, lovely woman who helped me, and we did stretches on my arms. I took that a little bit further, and I involved hired a personal trainer to help me with stretches and appropriate exercises for my arm. So I really haven't experienced a lot of issues going forward. I mean, there was very little pain from the surgery. The drains were an issue, but you move through that. I don't want to say it was an easy experience. It was not. It was a very emotional year for me, but I can't say enough about the great people at Henry Ford, the help and the assistance I got in it. Looking back now, it was a year, and there were certainly kind of not a great year, but some really positive things that came out of it as well. So not a bad experience.
So just an aside, do you have a high tolerance for pain, Becky?
I not that I'm aware of,
Okay.
but I really didn't, I didn't really experience a lot of.
What do you think, Dr. Atisha and Dr.
Yes.
Evangelista? What would you tell a
She-
patient about the pain that they might expect?
Yeah,
I think Becky's kind of tough.
We'll probably second this. The pain associated with lympha is not really there because we're just making a connection of the blood vessels, and so they can't feel that. But the drain is certainly patient's biggest nemesis. And unfortunately, when somebody has had a complete axillary lymph node dissection, the drain tends to stay for a while. But interestingly, and I think, a lot of the breast surgeons who I work with will say this, that it seems like when patients have had successful lympha, that their drain outputs decrease relatively rapidly, more rapidly than some. And so I think, the pain really hasn't been an issue. It's just the drain. And we can't remove the drains until they're putting out less than a certain amount. And so, we do have to limit the movement of the arm because of that.
Oh my gosh. Okay. So
yes.
how do you limit that?
I don't put people in a sling or anything, but I just tell them, like, please don't, first of all, we don't really want them stretching too much because sometimes the connection we make is tight.
Mhm.
And so we don't necessarily want them stretching above the elbow length. And I just tell them, please, limit the movement of that arm. You can certainly use your other arm if you need to. Your husband's going to have to do the cooking and the cleaning. Most people don't have a complaint about that one. Or you hire people to do that, or you bring friends over to do that. Usually the drain's able to come out at about 2 weeks.
Oh, that's good. I was going to ask you to quantify that. 2 weeks.
Yeah.
So you put up with 2 weeks for not having a lifetime of discomfort and disfigurement and immobility, right?
That's correct.
Right.
So-
I was just gonna say, it's really not, other than it's there. But I went back to work after a week. I wore lovely shawls. Nobody saw my drains. My daughter got engaged during that 2-week period. We had a little engagement party for her. Nobody knew I had the drains on. So it's, you kind of move through it and you do what you need to do. It was a pain, but it wasn't that big of an ordeal.
Well, we are out of time. This has been so instructive. This segment will be on the Pink Funds YouTube channel, as well as on our Facebook, as well as on our website, where you can sign up to give us an email, and we'll send you the link. And then we will reach out to you, Dr. Atisha and Dr. Evangelista, and to you, Rebecca, for any tips that we can put on one sheet that will also live on the website people can access. This is so great, because I know 15 years ago, when I was diagnosed very earliest stage, some people say it's not cancer, DCIS, my greatest concern was lymphedema. And so I'm so encouraged to know that there are 2 surgeries. One is preventative and one is
Treatment. That's right.
Yeah. So for further information, you can look up Dr. Dunya Atisha, Dr. Maristella Evangelista at Henry Ford Health System in Michigan. And we thank you. Have a great evening.
Thank you. You too.
Thank you.